Thank you.
Welcome.
Good afternoon to you all. As you've heard, I had the opportunity to co-chair the treatment optimization meeting that preceded the conference. And I'll be giving this high-level summary of the discussion on second line. Of course, the intention was my slides to follow the first line presentation. So in case there is some disconnect, I hope it will be resolved when the first line presentation is made. The context for the second line discussion, of course, is that as we anticipate widespread rollout of biologic monitoring, the proportion of patients accessing second line in low and middle income countries is going to increase. We looked at data from scenarios generated by CHAI, and we see that by the year 2017, 1 million people will be accessing second-line ART in the scenario where viral loads are scaled up. So it's within this context that we're trying to anticipate and optimize second line, knowing that many individuals are going to be accessing it in the near future. This is not a mere exercise, but actually is beginning to bear reality. And here in this slide, we see planned procurement from the South African government, which jumped up by as much as 150% for the year 2017. So, as we all know, the current recommendations for second line are either boosted atazanavir or lopinavir with a 3TC TDF backbone if somebody used AZT, or an AZT 3TC if somebody used TDF. So in our discussion, we zeroed in on regimens that will incorporate medications that are already approved, but not yet a reality in low-income countries. So the first discussion was around darunavir, and as you know, darunavir was approved way back in 2006, but is not widely available in these settings. And if you look at the reasons why this is the case, in most of these countries, darunavir was registered as a third-line drug, and so there is no legal or regulatory framework for it to be introduced. But also at that time, there were no ritonavir boosted fixed dose combinations available, and of course, cost was an issue. The situation has moved on now where we have 17 countries that have filed darunavir approval. And I think the discussion was in a context where darunavir is not yet a preferred protease inhibitor, and we think there's grounds for this to change and for darunavir to become the preferred regimen. We also realized that having darunavir that is boosted can be difficult, even though the ritonavir dose is 100 milligrams. The excipients to make this fixed dose combination makes a tablet quite big to swallow, and therefore boosted darunavir is a difficult reality to make happen. And there are plans to make a generic darunavir 400 milligrams, ritonavir 100 milligrams in the pipeline, and this would result in 2 pills daily as part of the regimen. And so there was a lot of discussion about using an alternate booster, which is cobicistat, which again is not widely available in resource-limited settings, but there are already studies looking at low-dose boosted darunavir using this booster that are underway. And I think this makes a scenario where this drug can become a reality for second line. Moving on to the discussion around the possibility of using integrase inhibitors in second line, we zeroed in on dolutegravir because of its superior efficacy compared to raltegravir, and also because of its once daily regimen dosing. And also, elvitegravir right now is only licensed for naive individuals. So, focusing in on dolutegravir, as you will hear from the first line discussion, dolutegravir is also a consideration for a second line discussion. And in fact, second line regimens for dolutegravir and boosted darunavir are already in development. And the advantages of this would be that would have a once daily fixed dose combination, which does not cross-resist with the first-line options that are currently in use. And therefore, one would move seamlessly from first to second line without any resistance concerns. We also think that because of the volumes anticipated, this would lead to a favorable costing that would make this a reality. So what were the recommendations therefore? We felt that there was enough evidence from published work, but also work that is in the offing, that darunavir should become the preferred protease inhibitor. But we acknowledge that there is need to identify an optimal booster. In this case, cobicistat seems to have an advantage. Potential manufacturers and purchasing agencies need to define the volumes that would lead to a more optimal access to this product. But also ongoing work and planned work into fixed dose combinations of dolutegravir and boosted darunavir need to be prioritized. When you think about sequencing, in the event that people use an efavirenz-based regimen, then the preferred regimen would be darunavir plus dolutegravir. And then in the event that dolutegravir becomes the preferred first line, in that case, the suggested sequencing would be boosted darunavir with 2 nucleosides. And as we mentioned, there is need to optimize the booster, in which case cobicistat seems to have an advantage over ritonavir. So with that, I thank you for your attention and would be happy to take questions.